I didn't know.
Otherwise,
Annie, otherwise
I'm just going to try to.
okay. So I can't really give you a proper breath sounds assessment. His name's Nate. His name's Nate Pearson. He's 35. Anything else you guys need to know?
Yeah, can we get a full set of vitals?
Our last set of vitals was his BP was 85 on 55. His heart rate was 128. His glucose was 6.5. Rest rate was 30. SATs were 91%. That was with a non-rebreather. And he's about 80 kilos.
Yeah, any medical history or anything?
Not that we know of. No.
Is he still on the non-rebreather?
Yeah.
All right, guys, so we're going to get Alex.
Nate.
So Alex is going to start this primary survey, guys. So we've got a high-risk, high mechanism injury with
Hi, Nate.
hypertension.
Nate, can you hear me? So looking at the airway patients, I do not appreciate any broken teeth. Don't notice any blood in the airway. Looking at his trachea, does it appear midline?
Yep.
Okay, trachea is midline.
Can we get a GCS, Alex?
Pardon me?
Can we work on a GCS?
Yeah. Just give me 1 second, I just want to hear about the sounds.
As Alex
Good
said.
breath sounds bilaterally.
Okay.
Okay, so sir, can you open your eyes for me?
He does the cane.
Does the pain. Okay. Can you raise your left arm for me?
No.
No. Okay. Does he withdraw?
He looks like he withdraws.
Okay. And I'm going to do it in all 4 limbs.
Yeah.
Okay. Sir, are you still with me? Is he vomiting?
No.
Okay. Okay. So airway is patent, GCS. And can you calculate that for me, please? We have good breath sounds bilaterally, normal heart sounds, exposing his abdomen. Can we get some trauma shears to help me cut this off, please? I can't get it off. What does the abdomen look like?
This has his.
Okay, how does it feel?
Soft.
Soft. Any bruising?
No.
Okay. I'm gonna, sir, just some cold jelly on your stomach for a second, okay? Jelly on.
No.
Do I have a fast?
Yeah. You got a GCS is like 5. All right, Fred.
Blankets.
I've got 2 18s in EJC. So
Okay.
yes. And has he received anything for pain? I forgot to ask about that.
He has not had any pain. There you go. It's disconnecting.
Okay. Hi, you got a guy with an alternate LC, GCS at 5, I think, and a hypertensive guy. I think he shoots for the airway. Hey, can we work on that and get our drum started?
Yeah, so, and I'm hoping to resuscitate before we intubate.
Sure, that's fine.
So he's got a big mechanism. Check MHP has been called, I'm going to pre-operate for a few minutes first, okay?
Hey, so this is what I'm saying, one for the quadrant.
Okay, so we've got 3 boomer
We have a
guys.
positive fast, the left upper quadrant.
Guys, we're gonna call an MHP for this gentleman, and I should clarify that.
Where was it positive?
Right upper quadrant.
Okay.
And if you want me to do all 4 quadrants because we have a positive fast.
How many units?
I want you to look at his lung. So we want to,
Absolutely.
an MHP, I want 2 units of blood,
Yeah.
right off the house right now.
The other side.
And then we're gonna get, whatever we can get, 2 units of FFP, and platelets if we can.
Subxiphoid.
Major.
pressure of 85 over 50.
Okay.
Okay.
Super
And
cubic.
he has not had any TXA, is that correct, guys?
He is not.
And then another one sliding bilaterally, please.
Perfect.
So this is left.
Okay, we have the MHP order set up. How many units do you want?
Okay. And then
2
right.
units? Okay, just pack of blood cells to confirm?
I've asked for 2 units of blood and then 2 units of iron.
Can I see the other side one more time, please?
That's 2 grams of TXA.
Okay. So I good lung sliding bilaterally. Heart is hyperdynamic. I have a positive fast in the right and left upper quadrants. Subxiphoid is negative, supracubic negative.
Okay. Guys, and we're gonna give him, we're gonna give him a gram, or 2 grams of Anzac just to cover with antibiotic, okay, let's cut this up to date. And then,
Do you want us to No, it's all on.
yeah, and we wanna pre-oxygenate, guys.
So
Should I
Annie.
give you warm fluids until blood pressure rise?
Not right now, I believe, I'm worried he's gonna be more blood.
Okay.
If he drops any further, then sure we can just do that.
We have a pelvic binder on the thighs. I'm just wondering if we want to adjust this.
Yes.
So I'm feeling the pelvis. Does it feel stable?
Yeah, hard to tell.
Okay, hard to tell. We have a pelvic binder on the thighs. Do you want me to take it off?
And guys, so Alex is completing a survey. Anyone who's talking, can you just listen? What we're gonna have to do at this point in time, we're gonna wanna move this pelvic binder, let's just wait, Alex. Might as well roll him, we look for any scalp blacks. Feel free to step before me when you do that. But we need some carries for someone to help, at least 3 people to roll, someone on the neck while we do that, and then we'll move the binder up.
And just while we're waiting to get some help, I'm just feeling for peripheral pulses in the feet.
Yeah, that right one is great.
Yeah, I have a slightly decreased pulse in the right foot compared to the left.
Okay.
I'm gonna fully expose the wound.
And Brent, that's 2 grams of Anzac.
Okay.
There's a special spot for that too, 6 TXA.
Do I see any other signs of any injuries? Okay.
Am I seeing pupillary symmetry here? Is that actually present?
No, normal.
That's normal?
Yeah.
Okay, guys, so here's our recap.
Dipping? Yeah, okay. So, where are we sitting on the MHP, like on the arrival of the blood product?
Yeah, what's our arrival for blood products?
Only 2 minutes.
Okay.
Because, so my concern from an airway perspective is his stats are clearly dropping. It sounds, is he moaning less? Has his GCS changed at this point?
Can I see the ultrasound again? Can I look at the
We're presuming that his GCS has changed, right? So I'm hoping that we, at this point, I know it's not the ideal in trauma, but if we can get some fluids in
So we
now.
can get 500 cc of oral saline,
Okay.
to get that started. So I'm gonna recap, guys, we have a 35-year-old high mechanism, trauma patient. Guys, bring it down, 35-year-old trauma, we've activated NHP, we have decreased LC, we need to secure airway. We still have to look for other types of blood bleeding, needs to be rolled and secured his pelvis. We're waiting for MHP, that should be here in a couple minutes. In the meantime, we're gonna give him 500 cc's of lomophistoid. We're gonna prep for intubation, expecting that he's gonna get hypotensive, so we're gonna have drugs ready and Patty's gonna take that over. After we secure the airway, then we're gonna roll him, we're gonna secure his pelvis, check the spine, check the neck, and then we're gonna address his other issues, which is probably.
I think you need a chest tube on this side. I have some fluid in the chest now on this side.
Okay,
I'm seeing some view
so
lines.
Patty, this could be contributing to your airway, do you wanna do an appendix or
Is there a pneumo, yes or no?
I don't see a significant pneumo. I have good lung sliding, but
I
I'm
think
seeing view lines at the base.
My thought at this point is if we have good line sledding on both sides, then I don't think we need to do the test tube before the intubation. So if we can get, pardon
This is
me?
the lung sliding I'm getting on this side. Good lung sliding.
Yeah.
Brent, 500 of warrants, normal saline.
Stats are still decreasing, and he's on 100% and PP10.
So Patty's gonna take over airway at this point in time. Alex, can you do inline stabilization with the collar off?
Do we want to?
Everybody be quiet to listen to Patty's drug orders.
So guys, my concern at this point is that he's persistently has low stats. I'd like to call anesthesia down to help us out with this. I don't know if we'll have time before they get here. We need to pressure bag the fluids in to support his blood pressure, and I'd like to start the Norapi infusion as well. Just start a point.
Whoever's running this, I've silenced the monitor.
So I'd say that's.
Annie, what do you think about a finger thoracoscopy for potential massive
Here,
tumor?
keep moving it out of the way.
Or do you want to do the intubation
We've
first?
got lung sliding on
Yeah.
this one, and let's do it.
Okay.
Alright guys, so I just wanna make sure that we're doing everything we can. It sounds like it's gonna be a risky intubation anyway. So I guess the question is, he's currently breathing, is there anything else we can do to optimize his hemodynamics before intubation, is my
So,
thought, okay?
Letting you know that we've got a unit, and what we see
Your
here.
unit is running.
And we've got another unit under pressure, we've got the crystalloid under pressure, we're gonna have the norepi going,
Noraki is running at
Yeah.
0.4.
and then I think that we should.
Because optimally, if we can, I'd like to wait until we have a little bit better pressure before giving any additional medications.
My only thought is, what about getting him to the OR and intubating him there where they can open the belly and deal with it all?
So I mean, it's a good idea, I'm just not sure
I
whether
don't
we'll make
think
it
it's
there.
You don't
Yeah,
think
I-
It's stable enough.
Do we want to call general surgeon and see down?
My apologies, do we have
Saying
help
your first unit is
anesthesia
done.
and surge? Can we call them?
You press that, Brent?
Mm-hmm.
Is that our most recent practice?
Your most recent pressure, you just get?
77 over 50, post the
That
500
one
less.
unit, I'm gonna assume.
You just got that one unit up, that's it?
And we're gonna get it, can we call for more blood, please, 2 more units, and we still are waiting for FFP, I'm assuming?
And you have the ketamine.
So we're having a total of 4 units that we've ordered, 2 of FFP.
So the other thing I think that I should mention in terms of predictors for difficult
Probably.
airway is that he does have blood coming out of his nose as well. I'm wondering if we can also optimize an OPA or NPAs, we can do NPAs, obviously because of the blood, but an OPA may be helpful, it's hard to know how he is to beg or breathing right now.
Okay.
So when I slide my hands under his back, do I get any blood coming from behind? No, no blood. Okay. So Patty, what do you need from me?
So right now, I think if we, so what if, is there anything else we need to optimize hemodynamics?
What was the blood?
There's a role for Noraki.
You're
We're
running.
already getting RFP, yeah, and we already have fentanyl available. I would like 2 large suction catheters available too, which is great, we've got one pressure in here. I think manual inline stabilization, I think if you can come around and get that going for me, that'd be helpful. And then the other thing that I'm gonna get you to do, Alex, is because he's projected difficult airway, let's mark the neck right now, okay?
Yeah.
Alright guys, so when we do proceed with intubation, I'm just gonna go through my plan, okay?
Yes.
So predicted difficult airway, Annie is phoning anesthesia to come down now.
Anesthesia and surgery have been called, and
Okay, great.
PPAP is on the phone.
Okay, sounds good. Alright, so then the other thing that we're gonna do is, we're gonna do ketamine, and we've got rocuronium available as well. He's currently breathing spontaneously. He has a high risk airway, so we debate whether or not to use paralytics for now in this case. Or not in this case rather. In terms of what I'm gonna do, so we've got our suction available, we're pre-operating as best we can, 86 seems to be the best we can get. I have my glide scope as my first attempt, I'd like a bougie up and available. I'm gonna look with this, if we have any further decrease in our sats, it'll be dropped to 80 is kind of where we'll stop, given how low we are now, and then bag him back up at this point if we get to that point. We also have hopefully a Colby tube available as well, and then Alex, I'll have you prep the neck for the service
So
okay?
neck is back.
Your second unit is in.
So your neck is cracked in landmark. Okay.
Repeat pressure after second unit, 77 over 49.
For supply, who do I have to get me some supplies? Who is
So you
available?
go to med center, have supplies and then something.
So Carol, may I please have a bougie? Sorry,
Oh, I got it. You guys,
11.
Alex is gonna take over TTL role, I'm gonna talk to hematologist, and airway's gonna be with Patrick.
Yes, I just get a bit of a.
We just don't have the 2 units to it.
And then,
I have asked,
And is our next unit on the way?
The 2 units, our transfused, we're waiting on the FFP.
Okay, and then we have 5 CCs. I like another additional. And then let's have
Another 500 transfused. And are you able to grab that, or should I go grab that?
Yeah.
on the right side. Can I give that chest tube kit?
So Patty,
Yep.
so we have general surgery here. Chest tube all the time for infusion.
Okay. Okay, so right now we haven't had as much change in our stats remain the same. So why don't we do the chest tube, see how that goes, and then we'll do the airway afterwards, but in the meantime, I'd like to continue with the MHP.
100%.
Because I think given his shot index
Absolutely.
is,
So guys, the plan now, so this, what is his name?
Dave or Dan or something.
Nate. So this is Nate, he's a 30-something-year-old male who is in a high-speed MVC on a motorcycle. He has a decreased level of consciousness, hypoxia, and he's hypotensive. Right now, we have Sebastian from General Surgery who's getting prepped to place a right-sided chest tube because when I did the fast, I did notice what I believe to be blood on the right side. The plan is to place the chest tube, reassess his hemodynamics, see if we can go to the OR without intubating, but if needing, we have him on an NHP, we have our medications prepared, and our proceduralist is pre-oxygenated. Does anybody have any questions or concerns about the plan at this time?
Do you want a blood gas for quick blood work?
That's not my priority at the moment. We can, but not at the moment. I'd like to get the chest tube in first. So Sebastian, whenever you're ready.
Yeah. You mind if I'm gonna just grab the ultrasound and do it under, I'm just gonna have a quick look.
Please. So we're stable, relative, with oxygen saturation dropping, general surgery can help us put in a chest tube. Not yet. And I
So I'm just like checking the right side here.
So just look and see.
Okay, you guys, I'm gonna recap. I know you guys were going for chest tube. Airway seems to be optimized with Patty. Thank you for that. I did speak with you, Pat, on the phone. And just to let you guys know, we are gonna give 4 units of blood. She said that we can give the 2 units of fibrinogen as well as with the platelets.
Yeah.
So did we order fibrinogen and the
And I'm gonna order that now. I'm just letting you guys all know. So this is where we're at.
Right, next 500 savings in.
After all of that's done, we're gonna call for labs again. We're gonna check fibrinogen level and do all of our blood
So your
tests
labs
again.
are automatically ordered Q30, the COEX, Q30 is the MH.
So after, yes.
Reassess, and then if we're still unstable, we'll pop it right.
Okay, everyone, so slight change of plan. We're gonna place the first chest tube on the left side and then reassess. If we're still unstable or hypoxic, we'll place one on the right side. Yeah, so Annie is now gonna take over again.
Yes.
Oh, sorry, yeah.
We mentioned it on your
Yeah.
Yeah, so Sebastian, we were talking about, doing a test. So he recommended, we wanted to have another monthly, we
being that equipment's not there, if you're
So
when you can set up just let me know if there's any airway changes on me, oh, I'm happy to deal and then I would be very happy if maybe
Guys, you guys, we are gonna work on getting this pelvic binder on properly while they work on chest tube. So Alex is gonna be doing that with our resident. And then after this, we're gonna complete our spine survey, our log roll, and then we're gonna go on to a secondary survey once we stabilize. I still think airway stabilization and further imaging is up there. Yeah.
So I'm prepping the chest here, I'm freezing, I'm making a cut, okay, I'm getting blood out, okay? And I'm placing the chest tube,
Chest tube's in.
chest tube in and hook it up to an atrium.
Whoever's recording, can we please record how much blood comes out of that chest? It really depends on what we see out of that in the first hour, or even in the first gush, to see where we need to transfer this patient, okay?
Alex, do you mind repeating the?
initially there is, I don't know how much there is right now, it's clearly
It's trending down, he was sitting at 86. Okay, now it's 84, 86.
He's coming back up.
Heat pressure after chest tube.
Left side again, post chest tube.
Drew, where are we at with our FFP? Is it here?
Not here yet.
Not here yet, okay.
And our fibrinogen.
Essentially about the same.
It was just ordered electronically for you.
There's a Patty chat about I'm essentially
Yeah, sounds good.
While they do this, guys, I'm just gonna give you an update. This guy's hemoglobin is 59. He's hypocalcemic,
Is the sound
hypokalemic,
monitor off?
and has a reasonable pH, but not great. It's
Hello, sir?
72.
So we've given
Sir?
half a blood cells do you want us to go ahead with some calcium
Are we still
And
pretty
Andy,
okay with that?
operating room is ready when you feel it's stable to, yeah, bring him up.
And would you like us to research here before we come on?
Up to you. Yeah.
Because we have no idea if he's got a C-spine injury, which is very high likelihood.
Right. I don't know, he looks pretty unstable.
Okay.
It is as is, so there's no.
And do we have anesthesia here? Are they here?
I don't see them.
Alright?
Okay.
Yeah.
True.
And can we work on access, what do we have for access, just to remind me again?
We only have two 18s
Is
in
this
each
like
AC.
as is or is it
Yes,
bleed?
that's the lines are great.
Yeah. Can we work on a femoral line for access so that we can start giving calcium and putting blood in a bit faster?
Where are we going to the OR imminently?
I think so.
My femoral line is not gonna be fast food to get to the OR. I prefer to put an IO in if you'd like additional access. Is that okay?
I don't, you can do that if you want to.
Okay. I can work out.
Are you wanting to?
Yeah, this thing's okay?
Yeah, that would have been.
So we have a chest tube in, we're gonna get some basic, now that we've done some resuscitation. Actually, I'm gonna pause, guys, can we just get a reset of vitals, see where we're at with everything, and then we're gonna look at imaging and then trying to get this guy to the OR.
Most recent stats 94% and most recent pressure 86/50.
Okay, and heart rate is 125.
25, yeah.
And what are we on? We're on basically, are we ready?
We're
Assisted
basically
breathing?
on 100% with 10 P.
Okay, and we haven't heard back from anesthesia at this point in time. Call. Okay, no, that's great, that's totally great. All right, guys, so we're gonna get an X-ray to confirm this chest tube placement. We'll get his pelvis just to look for any sort of other fractures. This guy's unstable. If you guys don't disagree, I think he's best off treated in the OR. Assume he has a C-spine injury. If we can get anesthesia down here, best to intubate him because of his mechanism and his C-spine. We already have blood, massive transfusion has already been ordered. We've given TXA, we've given him 2 grams of Vansa, and we're asked for some calcium chloride. He's actually hypovolemic and we're giving him a massive transfusion. We've had access. And then the only thing we just want to not forget, guys, if we're going to the OR, he's got a very, I don't know what's going on with his leg, he probably has vascular injury.
Yes,
We
ready
make sure
pulse.
that we reduce that and splint that if he's gonna be in the OR.
Not a trauma surgery.
Yeah. Is everyone clear with that? Does anyone have any questions?
I think we should intubate him in the operating room.
And that's what I said. Yeah, and that's what I meant to say.
have a look at the back.
Nothing at this point in time, so why don't we do something neutral like ketamine? Like
Okay.
ketamine dose for pain, unless you want something different.
I just, yeah, up to you.
Yeah,
Up to you.
I think that
Radio
ketamine,
pulse.
yeah.
And, you know,
So
obviously.
his sensor's off his finger again, can we put it on?
Is there any role in this patient, especially with
Do you know Carrie there, Ben?
further injuries?
I think
Calcium
we can-
chloride,
I
1
would love
gram
that.
using.
So guys, if we're gonna put an X-ray plate under, why don't we get that C-spine and look for scalp locks, make sure we're not bleeding out in the OR with the head injury, yeah.
Okay. Structure, we need to roll him together.
So we need another body to help with the log roll, guys.
Which way are
And then
we
Patty, can you be on the neck, just to solve it?
So we're gonna roll towards you guys. So we're gonna do this at the same time. So we're gonna roll toward, to your left. We're gonna roll towards your left. I'm gonna have a look at the back. I'm gonna palpate the C-spine and the rest of the spine, and then we'll get the plate under him at the same time. Is that okay with everyone? Annie, you good with that? Patty, you got the neck?
I do.
So it's on you.
Okay, guys, everyone's ready? Okay. 1, 2, 3.
So, does this hurt, sir? Does this hurt? Am I seeing any spinal deformities? No. Does this hurt? Does this hurt?
I don't think so.
Hard to tell if he's responding
Okay.
specifically to that.
Okay. Can you feel this, sir? Okay. And then, so I go in. Does he have any rectal tone? Normal. Okay. Okay. So nothing identified on this. I already palpated the C-spine. Nothing. Don't see anything on the scalp. When I slide my hands under the back of the neck of the C-spine, any blood or anything come out? No. Okay. So I don't see anything on the scalp. No lacerations. Okay. So let's get the board under him now.
Sorry, sir. Hard forward, coming under.
Can we just get an update that anesthesia's unable to come and help us today? I think we need to intubate him before we go to the OR.
Oh, so they're not available in the OR, not available down
They're
here?
stuck in the OR, and there's no
Okay.
one able to come help us.
But are they gonna be available upstairs, I
Yes.
guess is my question?
Yes. Oh, they are.
Because
They
I
are.
think if possible, it
We should
makes sense to go upstairs, right?
Yeah.
Sorry.
Yeah, it's kinda
All right,
My
1,
apologies.
2, 3.
Sorry about that, guys.
Okay, and even over a little more.
And who's on medications?
I am.
Yeah, can we give a very low dose, like 10 milligrams of ketamine? It's suboptimal, but with this hypotension, it gives them
Over a little
something.
bit towards me. Yeah, just let me
So,
grab the neck, okay?
Can we get a pressure bandage, please?
All right, my ICU colleague, I'm sorry to ask this, are you able to get me a pressure bandage, please?
Sure. You might help us.
Get me two, one for his arm as well.
Alex,
Do you know where to-
post ketamine, can you try to reduce that and see if you can
That's
get
10
a
milligrams
pulse?
of ketamine in?
Can we cycle our blood pressure after that? Thank you, yeah.
So, Drew,
Yeah.
when I look at his leg, is it, so is
It's
it
obviously
already pulse?
Is it a fracture?
No, but there's like lots of wounds.
And-
89 over 50.
So he's had the 10 milligrams of ketamine,
What's his level of, like, how is he if I move his leg?
He broke.
Am I able to
just,
level it
just,
out?
how does he do with just gentle traction?
Yes.
Okay, so
I'm just gonna do some gentle traction.
Nope. Okay, I'll be right back.
Want me to do an ECG right now, or are you okay for that?
ECG? No, we can.
Ready for X-ray when you guys are?
You guys want me to do an X-ray?
Yeah.
Yeah.
Okay, X-ray. 9 feet.
Yeah,
Clear. Can we get some hands to help this split, guys? Do we have a better pulse? Thanks.
So I'm reassessing the pulse now that I've been doing some gentle traction on his leg.
You've got a pulse.
I have a great pulse now. Okay,
Okay,
perfect.
great.
And there's your portable pelvic.
Awesome.
Okay, so
That's
can you
what it
bump the bed up, please?
So you guys, I've got X-rays of the pelvis. It doesn't look like there's an open book or anything concerning, but I still keep the binder.
Can we get another body reader just to help roll?
Brad, do we have any more blood?
It's coming.
We're seeing many for FFP, so far we have 2 units, is that right? Okay, before we hold them, guys, are we gonna need a sled or anything for the operating room that we need to have underneath right now?
Not a bad idea, yeah. Can we get a board?
Spine board?
This one, yeah. Board, yeah.
Do you wanna make that transition?
Yeah,
as
so we're
soon as
gonna put them in the binder. I don't see anything significant at this point in time.
Okay.
Nothing in the scalp, so if you're operating, like I'm not worried about them having a scalp left where you're going to be losing some blood. They did see the reduction, and they actually said that they get better pulse in the foot.
Oh, good.
So hopefully, maybe that's something you can ask your nursing staff to check his pulses, just to
Okay.
monitor that while you're in the operating room.
Yeah.
From what I understand, it sounds like anesthesia is available once we get up to the OR. If you're okay that we keep it in mind, we get up to the OR, you guys can intubate in there.
Okay, yeah,
Does that sound like
if
a reasonable plan?
yeah, I think that's.
Can I clarify and close the loop before we send an unintubated patient to the OR that anesthesia is okay to take over airway? Is there anyone that's available just to
You
get?
can call anesthesia, you
Can
want
I
anesthesia?
talk to them? Yeah, I just want to talk to them and make sure that that's actually officially the plan. Yeah.
And I also wanted to let you know, so there's been about 500 cc's of output from the chest tube.
Okay,
Okay,
okay.
and that's since insertion maybe 10 minutes
Okay,
ago.
okay, that's still okay, that's reasonable. We're not at the leader and we're not, we'll just have to watch that outfit. So whoever's in the OR, he's
Chest
going
tube
up.
output, yeah.
Watch the chest tube. If it gets over 300, that's concerning
Alright.
per hour, sorry. And then if you want to make sure that you check his pulses,
I think we do.
okay? In that splinted leg to make sure that we're not losing anything
Okay.
there.
We have a better pulse than we did originally?
Sure, post-read, yeah, that's good. All right, and then we're just hoping to look to speak to anesthesia before we send him up and unintubated, but I think to the OR before any imaging is our plan. Does everyone seem okay with that? If there's anything I've missed, please let me know.
Anesthesia's on the phone?
Okay, thanks. Either, I know you're caught in the
So
OR.
we want
and I'm
some
not sure you-
permissive hypertension is good here.
Yes, we do. So there's been concern, he's been like hard to oxygenate, but he's basically a non-rebreathe. He's about, what are
Except for
that,
the
rotary breathe?
Still
About
for
93%. There was concern whether or not they saw some blood in his airway.
I guess I wasn't so, it was
on the scanner.
So I would something
You can back off the normal.
Some of the other instructions felt more comfortable than we were the security. It's fine, precautions.
So we confirm with the earth.
Okay.
Hey guys, I think we gotta move to the OR. He's pretty unstable. I think we gotta start operating here.
Agreed.
Ready.
So is the operating room ready? Have you been
Apparently the OR is all ready. I just yeah.
This is
What do
anesthesia
you
on the
need?
phone.
Appreciate it.
on the phone.
What do you need from us?
I think it's patient. That's sweet.
We've been asked to intubate the patient because of their current situations, they would like us to do that. If Patty, if it's not something we feel comfortable with, if we want to try that intubation, we've been asked to intubate so that we can roll into the OR just with current staffing and their current situation.
Okay, yeah, so we did talk about the airway plan before, but I'll reiterate it again. Okay, so we're gonna keep the Norapi on for this. I know, again, not optimal for trauma, but just to support the blood pressure. Our blood pressure is better, okay, but we still have a fairly high chance of peri-intubation hypotension. We already have the neck marked. Alex, I'm gonna get you to kind of continue your role. My first step is going to be intubation with the glide scope and inline manual stabilization. So Alex, I'm gonna get you to stabilize the C-spine. If our sats drop significantly, we're gonna aim for 88 now that ours are a little bit better here. If we get to that point, I wanna hear about it, we'll back out and we'll bag him back up. I think at this point, I think our first look is gonna be our best look, so I would like to paralyze him, okay? So we're gonna do, first step is glide, second step is French, third step is combi tube, fourth step would be surgical airway, and Alex will get you to have a scalpel on hand for that. Okay?
So, our Carol, so I did ask the supply attendant for a sample energy.
Perfect, excellent. We have everything available and ready to go.
I don't have.
Oh, so
Is everybody clear with the airway plan?
Scalpel, please.
Yes.
Thank you. Okay. And so I have prepped the neck, we've landmarked already.
Okay, can I bump the bed up a little bit? We'll do one more airway pause and then we'll talk about medications, okay?
I have the scalpel first.
And we have federal available as well?
Let me know when it's
No, she's in entry.
I have 6 still because I didn't want to.
6 is fine. Yeah, that's great.
Okay. All right, guys, so we're gonna be giving ketamine and rocuronium. Given his weight and the fact he's currently in shock, we're gonna do full dose rock, so we'll do 120. And then we're gonna do a half dose or shock dose of ketamine, okay? So that'll be around 50. Is everyone okay
Yeah, I
with
agree
that?
with that.
How much ketamine is it already had?
I've given them 10.
Okay, that's fine.
subtle
Okay.
dose, yeah.
Is everyone comfortable with that airway plan? Okay, so before we give the medications, I'm gonna get you to come around and get my stabilization in place, okay?
Which side do you want to do?
Maybe great, and then stop right down.
I'm concerned that we're still waiting for blood products, so we.
And I'd like to just move this when we
Quite a while.
can.
Are you ready for it?
So we've given the pack red blood cells.
Yeah, caller how many?
And
We given?
2 pack red
We're
blood
still
cells.
waiting for 2 more.
And we still haven't.
So Betty, I'm not giving any medications, right? Go. Okay.
It's not common, it needs to be, it needs to be.
Okay,
unfrozen.
so,
Okay.
At this point in time, though, we.
yeah. All right, is everyone ready for the intubation?
Yeah.
Any other thoughts before we begin?
No.
Concerns? No.
I like the plan.
All right.
Position okay?
Yeah, I think that position is good. So, Ben, so I'm gonna try to give the medications, let me know when they're in. We're gonna have 45 seconds on the clock, and you're gonna let me know only when the stats go to 88. Okay? So I want you to give both of those medications right now, so 50 of ketamine and 120 of rocuronium. Okay, medications are in.
That's 50 ketamine.
We're checking.
Everyone quiet, guys, we're gonna do airway.
That's 120 of rocuronium.
Alright, so 45 seconds on the clock will be till 1907. I'll just gently support this breathing as we. Does it feel looser at all? A little tough. Alright, that's been about 30 seconds. How's he feeling?
Next unit blood is running.
Alright, easy to bag, that's good
Monitor
news.
silence, please.
Alright, so let's take a look here. Alright, so I have a view of the chords here. It's okay. Okay, and out please. Thank you. We'll advance it a little bit more.
Alright, let's get the tube up, so visualize through the cords.
Airways in.
Yeah, so
Let's
we're
cycle
just
blood
gonna,
pressures post
here, can you have a listen for me, that'd be lovely.
sedation, and then if we can have
And
someone
final
listen.
pressure is 82 on 40.
Okay.
You got it? Yeah.
Guys, I'm gonna do a quick recap.
Bilateral breath sounds.
Okay. All right, guys. So we've got an intubated, severely injured trauma patient that we're gonna forego imaging and go right to the OR. We've just secured airway. We're gonna keep him in C-spine precautions. If you can get that collar back on once you've secured that airway, that would be great. He's, from what I understand, has already had his 4th unit, I think, is going in now for blood. We're still waiting for FFP, but it's been ordered, and we've ordered a couple units of carbinogen as well. We are going to do coag checks, but that's all going to go on the hand of the OR. At this point in time, we've got a chest tube in, and all of the prophylactic stuff such as calcium, TXA, and antibiotics have been in. Got a surgeon at hand and anesthesia that knows that he's going to come. Like they said, they've asked us to secure the airway, which we've seen through the cords. I think that it's reasonable that if he's got good air entry that we can head up to the OR, unless we want a post-intubation airway just to make sure that we're safe and safe to go.
I think super good job here, and I'm gonna run up
Brent,
now
you're
and
next to you.
meet the patient up there, okay?
Thanks,
He
guys.
feels
pretty
cold. Do we have to
transport
him?
And we have a bear hugger on him right now, I don't think we have a Tim.
Would you like a post-intubation OG? Sure. And can we get a Foley in him before we go, as long as there's no evidence of trauma?
Chelsea's ready to answer for OG. Yes.
OR is ready for you. They want the full way and everything else to be done up there.
Okay, guys, hold up, don't delay, to the OR, go to the OG and Foley up there. And then keep the bear hugger on, secure the airway, and then we'll get him upstairs.
Can I get my board out from under him?
Sure.
So Andy, we're just gonna put in quick OG.
Oh, they want it up there now, they said,
Okay,
said
so
Julie.
we can do it up there.
Can you just get the board out real quick?
Yeah, so we need a couple extra hands. Alex, can you do 1, 2, 3?
Yeah, I got it next.
And, sorry, you have airway?
So we're going to the left towards Ben, to the left.
He doesn't need to
On
go
my
back.
count, 1, 2, 3.
Up, and board is out, okay.
Okay, back down, 1, 2, 3. Thank you.
Thank you. All right, and we're off to the OR, guys. And can we let, for any reason, can we let the blood products know not to come here, but they're gonna go up to the OR?
So you guys are gonna page switchboard, let them know that we're moving? Okay.
So as for transport monitor, this is a simism. Do you want to chat?
That's gonna go with, who's gonna go with the patient?
I can go with the patient.
Hey, I can come.
I think we should all just
Yeah.
be at bedside, yeah.
It's empty.
We can pretend it's.
Are we gonna run this through the elevator?
Yeah, we did it.
Or no, it's like kind of on the wall. We're gonna manage it.
Yeah.
Because it was dependent. It was like down. All the fluid is down. We could have
So
went.
it has to be unplugged and we'll go by gravity.
What did they say?
No, no.
Oh, you want to go next?
Yeah, because I was wondering if we needed
So, our medication to bring on route with us?
No.
Yeah, post-sedation, guys.
Take it to Sam.
I have phenylephrine, I have ketamine, and I have 80
You guys,
milligrams.
yeah, and we have 20 minutes to get them up to the OR with that ketamine, I think we're fine, as long as we support them with the pressors.
I just want to make sure, we should bring, oh, let's just bring this, that's all. That and fennel, I think, are our big ones.
Yeah.
And then, can we also bring some extra ketamine just in case these.
Sure.
Is there a physician going to the OR?
We're all gonna go. We're all gonna go.
An extra raw, please, again.
Yeah, that's 80 milligrams per
Okay.
Okay, they're ready for you.
So, time is 7:15, we should have time to get up to the OR, but
Ready to roll?
I would say the case.
Is it easier if I take this off? Do you want any of this to show the handover?
So what do you want this?
Can we take our polypack with us? Usually two of our, we never can. I feel like we have.
It's ready for moral policy. Is that been too full? Yeah. Are you guys ready to roll? As much as I like seeing you, but I'm glad you weren't here.
Yeah, no, it was nice. And then just 2 weeks of first like being a dad.
You guys have more than your, okay?
We're gonna do something, push something, or?
See you up there in a minute.
Yeah, I got it.
There's no panic, there's no panic, it's just a scan. You're not to get into the elevator, but once you're in the elevator.
I gotta swipe first. I'll do that
Did you?
first. Have we cycled it?
So after,
I'm trying to.
Okay. No, I'm happy with that. It's like, because we're gonna get. I don't know. Essentially, can get hypertension and tachycardia, as well as big pneumothorax. His chest is displaced. He's given 40 majority of blood. We walk around with the cover given yet to come. His ends up TXA, gram of blood, gram of chloride. He has 2 IVs and 2 central accidents. Standard for preventive health is definitely back. We are doing that. Thank you. Right leg that we produced it, that's okay. Chest he was going to put 500 needs to be washed out. And obviously, we are going to see that that does increase. And all of this, there's no number enough blood, obviously, we should blood in his belly. Sure. Or immediate laparoscopy. Oh, no, he just use it. So we haven't ordered, we just got our last 2 units of packed cells, we haven't ordered anything yet. And I can give you the story, and this is what his was pre-blood. Hemoglobin was 59. His fibrinogen was actually okay. He was hypocalcemic, which we replaced, and if you want more blood, we can.
He's had a total of 4 units.
Yeah, total of 4 have been given already. Yeah, and he's been on what pressure again? Just
Norepinephrine. And he's had a little bit of, there was some push dose stabilization for intubation, but mainly he's been on norepinephrine.
Yeah.
How much norepinephrine?
He was on 0.6 milligrams per kilo, 0.06 initially, but now I think we're actually at 0.6 milligrams per kilo. So we started on, and we'll see, yeah, 0.6 micrograms per kilo per minute. 0.6 mics per kilo per minute.
So a huge dose. So we need lots of volume. We need like 6 units of packed cells. You can order that power chart. 6 units of packed cells.
Whoever's on ordering blood, we need to listen to him. We need more blood products, please. So we need 6 more units of blood in addition to the platelets that we ordered, the FFPs.
So hemoglobin is 59, so we probably need.
This is pre any blood.
Okay.
Pre any blood.
And he's had 4 units since then.
He's had 4 units since that.
How many FFP are we on?
We have ordered 2. Okay. That we have, and we have not ordered any more at this point in time. The idea was hopefully to get a whole set of cattle once he's had appropriate education.
Okay, guys, who's going to do this?
I'm ordering 6 units of I'm gonna order. We draw more FFP if we're at 6 units of blood, so make sure we're 1 to 1 on packed cells, the FFP. Okay, so then when we ask for 2, we need to start 4 more flight. 4 FFP. 4 more FFP, so health budget, we're gonna go over and 1 to 1 after now on. Whatever the protocol is, usually 1 to 1 after, we're gonna go to 1 to 1.
Ailson has received handover.
Yes, we received handover, and you are now going to take over. You guys are ordering more products, and we're going to step over.
Okay, thanks, guys.
We don't have an ORA at this point. Archie, could you say it? We're going to need your help. Is that okay? Yeah. Thank you.
Are we taking it?
Yeah, I've done that. Okay, on my count, guys, when you're ready, there. I count of 3. 1, 2, 3. And down. Okay, and on count of 3, taking them all the way. 1, 2, 3. Okay, what is the one for? Oh, it says 1 up for 6 more. It's not our neck now? It's to bring up the hands? What kind of setting for you today? We didn't put them on the ventilator at all. Okay, so we were maybe right. So 505 are we? Yeah. There's no like big 3. Now, 100%. And what's your so, we were doing it. I think since we've been paid, yes. Okay. So I'll put this in the room. Okay, 1, 2, 3. 1, 2, 3. Okay, you want me to start getting that last line in? Because that will give us a more accurate.
Can I just get this out of the room?
So if you're not participating, please hold off on all the. You want to make sure to get something to cover his body. Okay. Yeah.
And then put a, can you put an outline in?
I put an outline in.
Okay.
I'm gonna steal the other stuff.
Just we'll move slowly.
Okay.
There we go.
Okay, what's your latest lab?
Have it set up. Always not set up. Okay, so I'm just gonna get this side.
Yeah, we can
Hey guys, we're gonna do our surgical safety pause. This is Nathan here. He's coming for a trauma laparoscopy. Kind of exploratory at this point. No known drug allergies. He's had some ANSA, he's had some PSA. Yeah, concerns.
yeah, it's a little bit athletic, we need another blood work. It's should be, 100 with the 4 units, but we really need another set of blood labs. When's the lab coming next?
They just haven't drawn some more labs.
Okay, so it'll be a few minutes before that.
So I'll go scrub if you guys don't mind getting ready there. Alright.
So we've been having a unit of blood on the blood warmer.
We just got blood, Scott.
Okay. Let's start with 2 units of packed cells and then 2 units of like frozen plasma.
Okay, we're not actually running this through.
Someone maybe help Sarah check the blood.
Okay, and if you want that
Bonbon, is this mine?
I won't need any help after this point. So I'm actually independent as soon as I start him.
Yeah, I guess. We've got these. Those are.
Okay, so he looks volume underhydrated as we all think, very collapsible wise.
Okay, super.
But it looks like an achievable site.
Yeah.
Let's give them a liter of lactate awareness to get in faster.
Okay, I'll get a leader. Okay, you don't have to, okay.
So art line is in.
Okay. And the art line is showing what? Is it still 94 over?
Yeah, still the same.
Okay. Great. We can start cropping.
Give me 2 seconds and I'll be almost done.
Okay. We should probably listen. Who wants to examine them? Okay.
Yeah.
Oh. Did I hear it? Is he getting good air entry on both sides? Heart sounds normal. Are the nurses ready to start pumping?
Yeah, do you know if he has any
As soon
allergies?
as the allergies
Okay.
line is in, we're
Just
fast.
got the alarm going.
Okay.
going in.
Someone let me know when the lab gets stuck.
Okay, all my drinks can come off now. We just need to be careful with them coming off. Don't pull it behind. Lab work is back too. Second set of lab work. And Dr. Nunez is available if you need to talk to her.
Okay, the heat score is still 55, so we need 4 units of times 12.
Okay, we've got our, okay, so we've got our sponge down, so that's gonna be our fastest transfusion slot.
We're doing actual going in pretty fast. We need some calcium chloride, probably in the ground over about 20 minutes.
Yep, that's good. We just need to connect it with the ports now.
Platelets are 30. Are the platelets on order or are they
Oh, okay.
We're not ready for
Ready? Our platelets on their way. Our platelets, okay.
Yes.
Okay, the platelets are ordered. Platelets are, are we good to prep? Okay.
The potassium is 2.8. So we should,
Prep the binders? Okay. I'm doing brown, so we're good to, incision. Okay. Double layer. Double layer prep. He's on the negative line. We got your credit on the side. Yeah, brown, you're ready to drink. Get over bottom, side, fine. He's actually skipping calcium. Correct? Okay, can I give like 5 now? Just because to set up another 3 right now.
okay, it's like vibration is 0.8, so we need, vibration word. Is that?
Right? Or whatever you guys do.
Whatever the, is there word maps for that? Some of the word on the power chart will tell you what you get for, a low vibration.
Okay.
I'll pull up my pen and throw it on here. Start with double, please. We're gonna light behind there.
Okay, yeah,
You're on? Okay.
Light hand on the front.
okay.
Scalpel in the field. Okay to start?
Okay.
All right.
We've got Nate helping. And we're doing a laparotomy, go out and do antibiotic cardigan. You got this downstairs, correct?
Answer up downstairs.
Can someone watch the monitors for me and let me know if the heart rate goes up over 120, if it changes at all, the blood pressure drops? What's that?
Yay.
Right, yeah.
And have we spoken back to the pathology yet about, because that might be even quicker than pulling up our back transfusion protocol. Do you want me to get her on the phone?
To do.
To just give us an advice as to what we're gonna do?
I think we're okay. All right.
And you've got pottery with Tesla?
I've got to get a little bit of Johnson.
Lots of blood here. Can I get, lots of blood. We're gonna need some, ABD.
Thanks, I know. All of our items right now. And I've asked them, I think they, I believe them, I asked them for FFP at this point because we want to work with them.
A lot of blood here.
And our platelets are very, we're using all the ones.
They're in the room.
Perfect. Do you guys have those? Perfect. Okay. Okay. And for the fibrinogen, I think we're good. I got one right here. She's used all of that. Okay. Okay.
That's your so that'll be what 15 total that we asked for.
Yeah.
All right. 8 has gone in already.
Okay, so you want 2 to 1, not 1 to 1.
Is that okay?
Lots of blood, eh? Lots of blood, yeah. We got 2 sections. Yeah, we've got a couple.
I just figured that it was just gonna take time to get it to 34, so we could go on if we didn't start drawing. Okay.
Over here, lots of here.
Okay.
Let's see.
Okay, I'll call you back if we need you. Okay, thanks. Bye-bye. Okay, so 4 grams of I can try. I'm not even logged in here yet, so I can try. I'm ordering 4 grams of
Okay, 5
knowing that I've never actually ordered it before, it might take a little second.
Those upper quadrants. Let's put some pressure on that.
And ordered Jen. Okay, yep.
That side.
Good. And have okay, and we've got 2 more
Possibly.
ready to go.
We're just basically packing pressure right now. Active splitting laceration. And bit of liver lacking. So we're just gonna pack it, and I think they probably have to take it in and out. Yeah. Give it a second. How are you guys doing?
Looks like
He's on his own.
yeah.
He's worse on labs than he is on monitors right now.
Okay. Yeah, very easy.
I think we've had 4 units. We've had 8 units in total already.
Okay.
And,
8 units of practice?
yeah, and
I thought it was only in 4. We did 4, but they had downstairs. 4 up here already, okay.
Yeah. All right, let's take that.
So then, hematologist suggested not 1 to 1 with FFP, 1 to 2. So if he's had 8 units, we need 4 units of FFP. 2 have been in, so we'll make sure if we get blood bank to send the other 2 whenever they're ready. Okay. I'll call the blood bank. Okay. Now is our warmer connected? Do we have him actively being warmed right now?
yeah, the upper and water floor
He might use something on the okay. And what is our temperature on? Do we have a thermometer? Very generous.
So,
Okay.
what was, you never got the medical image here?
No, he was stable before he had.
He was kind of confused, so there might be a intracranial pressure problem. Maybe should we bump up the respiratory rate a little bit?
Okay. What's your, harmonics number?
Yeah.
So this would be with our, now, what time was our last one? We're done.
So I just did a blood gas.
Okay.
Do we have any results on the hemoglobin and
7.24. ECO2, 50. OSHU, 49.
A PO2 of 49?
Yeah, on 100. Yeah.
Okay.
All right, what are our volumes, sir? We did good
I got 5
volumes.
sentence you can have.
500?
So we're getting 25. Not that bad. Okay, so 5.
so let's go up to 10.
Yeah, okay.
Right, sorry. Is that fine?
Did the extra volume drop his blood pressure at all, or?
We just decreased the peak, did it drop the blood pressure?
No. And the ventilating pressure is still peak
33.
pressure?
35.
Yeah, I think a little high there. No, it is plateau. Auto flow means it's a plateau.
It's not
Peak
actually,
pressure is
it's into like the
plateau. Okay, maybe we need to listen to the lungs again.
So we still got.
How's our chest tube? Are we still?
I'll check.
Keep going now.
Blood pressure's dropping a little bit more.
Got it?
Yeah, so I'm checking our chest tube drainage. Is there any change from where they marked it? They marked it at 7 o'clock. It was at 500. What's it at now?
What's the central pressure? Sort of limit?
I didn't hook up a pressure bag to the leg.
Oh.
I'm just using it as a furnace for the
Okay,
pressure.
yeah.
So we have our stats dropping, let's put the peak back down to 5, that's what are lungs sounding like?
What's that allowing now?
Okay,
1100.
blood pressure's dropping, Becky. So you still want a huge dose.
You want me to go up on that dose?
Everything okay? We just took the spleen out, everything all right?
We're at heart rate of 160 and a blood pressure of
I think we need to
75.
get them two units of bicarb,
Okay.
another gram of calcium chloride.
Okay.
Um,
Well, let's just recap.
okay, when I examine the chest, am I hearing good air entry on both sides?
It's really hard to hear. He's got the chest tube on the one side, the other side.
Is the trachea
There's
central?
ultrasound available if you want to
Trachea
try that.
central?
Are you bringing this ultrasound? Calcium is in, our
Trachea
program,
central.
calcium is in.
Trachea is a little deep.
Oh, is that, we use that one.
Inside,
We use that one, what do you think?
it's going to the left. And is the chest tube on the right or the left?
The tube's on the left. This is the
Okay, so we might have
So
a.
it's tension on the right, okay?
Yeah, who can-
Just a minute.
You want me to needle decompress it? I'm not going to chest tube, I can needle
Yeah,
decompress.
flip the ultrasound out and, it's right there.
Kind of here. Yeah, go over. Yeah. Very good. All right.
Ultrasound through.
Okay, yep. Put it on abdominal, flip that, screen up,
This one?
abdomen.
Oh, it's this one.
Oh, it's that one?
Yeah.
Oh, okay, good.
Okay, so we see.
It's a new one.
Okay.
So to be honest, I haven't done POTUS training, so I would just literally look at compression work, so make a regular line. Okay, needle going in, withdrawing back. Do I feel a gush of air?
A huge gush of air.
Okay, so I'm gonna leave the needle there. We're gonna tell our general surgeon that.
Where do we get one of the emergency, products that can make the chest tube in on that side? Or one
What
of
if we send them
the.
in? Needle decompression on that side like that.
Patty?
Yes.
Do you happen to be available to help out in the OR?
I do, I can go find a chest tube and help out.
All right, I would not do.
Okay, so another question. Has our stats come up since our needle's in place?
Yes.
Okay, so our stats are coming up. They were 82, they're 86. Our pressure's coming up a little bit, slowly, but it is coming. Our heart rate is dropping, so that's good. Seems like that's going well so far. All right, so I'm coming in to do the chest tube. This much there's a needle in place right now. Okay, sounds good.
Let's leave this one for now.
I'm just gonna scoot underneath the steroids right here.
Do you need any help? Pat, anything?
I don't think so, if you just
Start with the scalpel, and you can probably do it from under here. But I don't know, okay, so our stats are back up to 94, our heart rate is 150, right here, perfect, as our triangle safety.
Okay, and some prep. Thank you.
Okay, I'm prepping the area, and I'm making a cut. Okay, do I get a nice additional whoosh of air? Yeah. All right, and there's a chest tube going in, and we'll hook it up to an atrium as well. Okay, and I'm gonna take it with my. Thank you, and let's cover that with an occlusive dressing on the top of the chest. Okay, let's put
This underwater suction here.
Okay, everybody's moving the dressing. Okay, here we go.
Really easy, squeeze out. Put some pressure down now. We're gonna take these packs out in a second, have another look. I think we're gonna just have to pack and leave them open.
Okay.
So the ICU. How are you guys?
So we're still waiting on some blood products. Chest tubes in. Respiratory status looks better, right, Scott?
Yeah, blood,
Have they sent out the platelets yet?
Yes.
Amazing. So I can, Scott, I'm gonna deal with some more fluid issues over here. So that we can agree.
we're going to drop the norepinephrine here, it looks like it's on that industrial dose.
And did they give us FFP as well? Yes. Perfect, thank you. So that's 2
units of FFP that have previously gotten units of FFP, they send up now?
Yes.
Okay. So that's 4 total, and then 4 units of reflux and Packard's blood cells. Since he's been in the operating room.
Yeah.
So that, okay.
We got the big ones?
So these are the 2 pack cells?
Yeah.
Okay. So how's the pressure doing?
It's 102 over 56.
Okay, so you were trying, or we're coming down already?
Yeah.
Okay, so,
Recess 95, pulse is still 130.
okay, 2 abdominal rolls in, okay?
We just can't turn off the alarm.
So that's done.
Silence it for a minute.
Our plasma that's done.
Eyes for net.
So another 2? That's our here.
Are we, what's happening after we reach them? We still need to do a ceasefire X-ray? And is there other medical imaging? I guess he still has potentially lots of fractures that are undiagnosed.
Can I just jump in here and say that the ICU doc is completely tied up with something else going on, but they're prepared to accept this patient. He needs to go down to medical imaging for a full body trauma and scan. They're expecting the patient down in radiology. And the ICU team will not be able to assist. So if there's anything that needs assistance, it will be between the surgical team and the emerge team.
Emergency ready, we can get a protocol infusion set up for us so that it's ready to go, because we'll need some drugs for transport. So we can, I'm sorry, I don't see anybody's name. Ben, you can get a protocol infusion set up for me based on weight?
Betcha.
Thank you. You can come with our drugs.
Okay,
Are you, starting with that, you're folding fund, you want fennel, medallion instead? Yeah.
So, are we able to go to ICU after CT?
There's six.
Seniors book,
All of our counts are correct.
Hey, Seth.
Hey.
Never go near a good scalpel.
Yeah, we're making up instruments.
So why don't we go on the left side, because then the ICUs are gonna end up using probably. So we put do a summary before we transport, so that we're all on the same page with what's been done, what's been given, what the plan is next. Yeah, that's how you're up. There's someone in bed. Oh, there is someone in bed?
Is it full?
Might have to go down a bit too. We're on
On Anastasia's count. Okay, count to 3. Okay, 1, 2, 3. And down. And on the count of 3, we're going to slide. 1, 2, 3. Perfect, guys. Oh, you got it down already. Oh, it's in.
This is actually really good to know. Yep, it works. It's an innovative. It's an open line then, but it works. Okay, so there was a request to do a summary before we go downstairs, so everyone is going knows. Scott, you can come to me if you want me to cover it.
Let's go,
Okay,
guys.
so this gentleman, whose name I do not know, 30-year-old Nate,
Yeah.
30-something-year-old man, MVC. We know he's got a splenic and a liver laceration. We know he's also got an open fracture, at least in his left leg. We're unsure about a C-spine injury. Came up to the operating room, packed him, are going down for other scans. At this point in time, blood-wise, he has 6 units of Paxil plus. That makes 10 total, because we had 4 downstairs and 6 up here. We have 2 units of FFP that have been given, 2 units that we're waiting on that are pending and that are going to come up. We do not have our fibrinogen yet. We ordered 4 grams. It is pending. We know he is coagulopathic based on clinical as well as laboratory evidence. We treated the calcium a couple of times. We know he's hypokalemic and we know he's cold. Do we want to get warm IV bags to transport him so we can pack him around him because he's going to get more cold downstairs. We don't have the body warmer to go with him. Any other thoughts of anything? And ventilation has improved since we put in the second chest tube.
Can we have a warm blanket to put around his head if we're worried about cold?
Anybody have anything that I missed or can suggest?
I don't know if you said it or not, but propofol is now running at 1 milligram per kilo per hour.
Okay.
Like Blackwood actually took the
Clean it out.
Clean it out. Thank you.
We still have some already.
Running, but it is going down.
Okay, sorry, I was worried about the protocol.
And we just did a rapid running with no one else.
Yeah.
And you have some.
And packing.
I have just checking with me, and I can drop it down.
I think open I push those, so set it around for.
Okay, so grab a to-go kit of like our little okay?
We were.
Radiology ready.
And then we got the mixed ranges for the doxies.
I'll ask.
All right.
Esther, do you know if you have some bear huggers for transport? Those purple bags?
No.
If it's a bolus on the
You want a bolus on your feet?
Radiology is aware that we are on our way.
Okay, everyone, there's room for everybody in radiology, so everyone.
No, there's no setting for Nora. We just want it up to 0.3.
Okay. And let out.
And we do have gravel. We do have gravel.
Hang on, guys.
This is,
Okay, I can. You're ready?
Yeah, we're good. Sorry. Nora, if you went up to 0.3, you have your
Yes. Here. Mine's in the hallway. We can just carry over. I got my
You don't want me to do everything?
Sorry.
That's okay. I can just up to the side.
Bear huggers, minimize your exposure.
We're used to it. Drink Coke for hours. I like how we need signs.
Oh, and I wrecked the door.
It's pretty sad.
It's, that so many people are, now that this is a through corridor for ICU and all that,
Oh,
people going home to get marked. That's why there's signs.
yeah.
We never used to have signs.
I know, this is the first time I've been seeing signs. Spinning.
Alright, so what are we doing here? We're gonna do a full trauma pan scan. Trauma pan scan? Yeah. Looking for any suspicions? Anything from the award? We haven't been assessed for any accident injuries at all, and then they just look at me. Yeah. Okay, yeah. So. Just kind of spam. Yeah, he exactly the same.
Do you have a board?
Yeah. We're there.
Well, I wanted to know if I could put 10 horses in.
Yeah, let's get the warming bags out.
Well, it's easy enough stuff.
I had to learn to. We used to do that in government. I used to.
Yeah.
Yeah. So we're. Yeah, but well, I was watching. Yeah. Did they have there? Oh, they put that on. They want to
This, okay.
Do the scanner?
Just ask that.
I'm just a short.
Yeah, I didn't know where we were going. All right, I got the head on the count of 3. 1, 2, 3. And down. Okay, hang on a sec.
What are you two guys doing down here? Covering your assignments. Come
You guys ready? We're gonna go all the way or halfway?
Are we on that
We're bringing the board over. Yeah.
Not the board, no, storage sheet. Yeah. Yeah, we're gonna go all the way over.
Okay, 1, 2, 3.
We need to go up.
Hang on just a second.
Moving the bed, be the ones coming down here.
Hang on, hang on, hang on.
It's a both the flow situation.
Most of the time you get it done before.
I don't know where the one.
You guys want to head in?
Otherwise I'd be separate, but I can still.
Okay.
Minute 2.
Yeah, let's do it. 1, 2, 3.
Okay.
Okay, so since I see he isn't here though, it's still us. So he doesn't look a heck of a lot different on monitors, other than we have the sat. Maybe we should have we have time to hold on. Oh, we're cut now. 95.
2, 3.
Okay.
You know, moving to
Yes, and minimizing like this would be nice. Or at least I can.
Thanks, sir.
Can I pretend that my coworker brought me a ventilator? Can I pretend I have a ventilator?
Yeah, exactly.
We're not gonna.
That's perfect, and then this should be off to the side as well. Wherever.
Okay, we're good.
That's real, that's true to life.
Lines.
We're gonna have enough lines.
We're not gonna have, how far in is he going? We're not gonna have enough lines
Full
tonight.
pan scan.
Yeah, he's
Yeah,
gonna go
he's not-
to here, so we need.
So we need to sort him out here.
Yeah. You have an line or?
I'm not actually scanning. I was just gonna put it in, just like in as far as.
So I'm not worried about the ventilators tuning, it's just the IV tuning.
If we had an actual CT tech, we would probably put it up first, but,
I didn't, I couldn't find a head for it, but we want one. I wasn't sure. Don't you bring it back for a bit? I can come back if you're.
They got stuck underneath.
Sure, it's managed, okay? It's coming back through.
I know why it's not there.
I get that off.
Is that for the computer?
Yeah, that's for the computer. Just leave it.
Yeah.
I don't feel like you have an answer.
Take it a little away from the pen. This is like the
Nice work.
ribbons. And door.
Everybody loves it. Nobody loves it.
I just walk. You're on.
So sorry about that.
So
I could put some Velcro.
We usually put it on the bed and
Just like lower than half of it,
okay, so I think, can you put him through it? We'll see if we have enough time.
We can just tuck it. You're good? Yeah.
I'll put, I can do this. I remember.
I can try the bed though.
Okay. We're not actually gonna scan.
Here. I'm not in there, I'm watching the monitor.
Okay, so we scanned him. And what is the next part of the scan? Okay. Okay, can we get an contrast? Priceless. Who's monitoring? Right, so we have a moderate sized subdural with backward midline shifts. We should put neurosurgery on the phone. Insert decompression.
67 on 22. And right there to 160.
That's more than expected.
Okay, so is it out of the scanner now?
Yep.
Okay, we're gonna go. And go back in this way.
Yeah,
You guys want me to call it? I can call her. I didn't read that. I can call her.
this so I can raise that?
Okay.
Okay, what's the,
What
okay,
was
listen.
Do we have a central pressure?
I think it's not.
No, central venous pressure? Just that venous look distended.
Okay, so what do I hear breath sound like?
We need to give them, this might be Veritek.
What do I hear breath sound like?
You just take contrast.
Easy?
It's the first thing I think of.
Okay,
Sorry.
so,
Allergy,
can
right?
you have Bentley down here with you?
Oh, look at this.
So the rash.
Oh, okay,
So
so
epi.
assume anaphylaxis. I got an allergy.
Oh, we better be right here.
I always bring up the right to go kid. Okay, so how much epi do you want to give me? Do you want me to just give it?
I would give them 50 mics intravenously.
Okay,
And
and
then,
then I am as a depot, do you want a depot as well? Because you're gonna want that 50 mics is gonna go quick.
I think we should
I-
do that
I-
later.
Yeah.
intravenously.
0.5 IR, and then we repeat that
Do we have an
5.
auto injector or is it just?
No, I got
Oh my gosh, yeah, IV, so it's
I got
point one, isn't it?
So, well, we're gonna get 50 mics, we're gonna get 50 mics
Half a milliliter.
of the IV, and then we'll give 5 milligrams of IR, or
0.5.
0.5 milligrams, which will be 5 cc's of this, and we'll give it IR.
Do we have
Pardon me?
we're willing.
This is all I got, this is all I took out of the OR, so this is not covered here. Oh, there's a crash right here. Sure, that'd be great. We'll get some steroids on board, get a new dose of steroids, and we'll take 6 hours to work. Did the epi do anything? Not yet. Okay, do you want another 50 mics IV? 50 mics IV?
We need more volume.
Yep.
We need a liter lactator bolus or.
How much is going right now?
So we had the level 1 that should have probably still been attached to his leg, or I think it's probably in the hallway. So let's get some volume. Let's give him a liter fast on that level 1.
Who's doing these orders? So is our nurses gonna run for these bloods?
I have no idea where anything is down here.
So we're gonna
I
get
was gonna
guys,
If
we're
we're here, we
getting
can do
the
it ourselves.
He was just checking all the medications.
They are disappearing.
Okay,
Alright, well, I will go grab the things, but yeah, I would suggest.
yeah,
Crash
I
cart
started
idea.
here.
We're gonna call a code overhead,
Yes,
we got some other
code.
code, we just wanna get some bodies here, we'll get an emergency nurse so that we can run some fluids, we can get the epi, get the crash cart, we'll do what we can with what the drugs we have. And then we'll close that loop and make sure that we can resuscitate this patient here.
We've got no place else to go yet. I see what's ready for us.
And there are things we can consider, so we can consider giving additional doses IM, we can also consider switching our Nora infusion.
We have infusion, check
Might
right
be
here.
another kind of way to go around,
Crack
we
it.
can probably give steroids as well, we can do the Ventolin as well.
Okay.
whatever that's. Yeah.
Okay, so why don't we why doesn't one of our nurses that came for the code blue, whoever those code blue nurses are that arrived? Okay.
I'm from the OR, but I came anyway.
So the code blue, Chris, are you our code blue nurse?
I guess so.
Can you get an epi infusion drawn up, please? An epi infusion.
Okay.
Because we got IM and I can give sidearm, but we're gonna want him on an infusion.
Okay.
And we'll start at point 1. And if we have to go down from there, from on the north, we'll go down on the north.
Like a, no.
Easy good? Good. 70 on
Go back to the
3.
surgery.
Sure, so does that come on your crash cart? It should take a couple hours.
I don't know, I bring the crash cart, I don't know.
Vitals haven't changed, we need to do another ultrasound.
Okay. So should we call one of our staff to do a fast survey, or,
Or I can look at the CT scan.
yeah, do you wanna look at the CT?
Oh, look at this wonderful.
And if we can get a leader come on our demo line, thank you.
Any other confusion or?
Okay.
So we have the subretinal, we have to get aerial fractures, facial bone fractures, skull base fractures, pneumocystis, brain injury. So you have 12 no surgery. Correct?
RV compressions or
No, not this is, no. Ventricular and there's a little left-sided chemothorax shift to the mediastinum. Splenectomy is expected grade 3 liver lax as well.
Okay.
So potentially a source for ongoing hemorrhage. Packing is noted in place. Hemoperitoneum is small volume. Left side rib fractures. A lumbar transverse fracture.
There's only gonna be one line.
If the neurosurgeon calls,
And so that's an order to sidearm, if you don't need to use a sidearm. Thank you.
There is.
Have we drawn off one word?
How many minutes or hours would it take?
Okay, how about we draw from that right line, so one word, and we can call for, yeah, and then we will call the last people and say it's already drawn, and then we'll draw it for them after.
We need a surgeon that will actually do that. Who's the general surgeon? Getting in here.
He's having too much fun out there.
Last year, okay.
Sebastian, we need a surgeon.
Okay, so I've just sent off another set of blood to see whether.
Can you do a verbal?
I'm the resident from ICU, is there anything for handover if we're gonna transfer?
So there's a ton to hand over to ICU, in that we have an unstable patient right now, blood pressure 70 on 25.
It's coming up.
Pardon me?
It's coming up.
Okay, so we have an unstable trauma patient with an open abdomen, a subdural hematoma in the head with midline shift, and anaphylaxis occurring all at the same time. We've treated the anaphylaxis with both IV and IM epi, and some sort of steroid, whatever was in there, and fluids. We just sent off blood work to see where we are coagulopathy-wise, because we know there's a coagulopathy. We know he's probably cold as well. We tried our best to keep that under control, and I believe we were calling neurosurgery. We've been talking numerous times to him about the massive transfusion protocol, and he has received a bunch of, I think, 10 units of pack cells, 4 units of FFP, 4 grams of heparin, at least 2 grams of calcium epinumber, 1 gram of calcium with us, some 5-carb because he was acidotic, and tranexamic acid. Did I miss anything? Yeah, he's got 2 test tubes, and he's had a splenectomy.
Liver lax.
Liver lax, which are packed.
And then you guys are contacting us.
I have a page of neurosurgery.
What's the propofol doing now?
The propofol is at 1. We can drop it a little bit. So like, what's that, 5? And see how it goes from there. And infusions wise, we have them on Norepi originally. As soon as we stop it, so it's an anaphylaxis. We then put on an epi infusion as well. And so we'll titrate them both, assuming he'll need more epi or a little less. But that'll probably cause him to be more macrochronic as well.
And we've only given 1 dose by it, right?
2.
We did 2,
Okay, 0.5.
So this patient is now finished his scans. He's on the way to ICU, neurosurgery on call, and they will expect the patient and transfer later tonight. So thank you very much. Everyone's going to head back to the Good job.
You want to move out of the scanners?
Did you guys hear the patient line? So you call more and more going by? There's like a super outside patient was like, this looks a little bit dire, call the morgue. And I was like, excuse me? Like, I was like, she's like,
maybe I'll park here instead.
yeah, that's probably a good idea.
Yeah.
Pull it up to the hall.
Sorry.
Yeah, no, it's all right.
Keeps me going all day.
Anesthesia to be super jealous. See all the stereotypes happening here.
This is a rare moment for radiology and anesthesia to be talking. It's very rare. You guys even ordered images.
Just lazy.
send us an
Hey,
email?
Paul, there's chairs over here. You want to come
You like to hide in the shadows, don't you?
Right. Yeah. All right, we're good. True. You don't even need us then.
Special
Alright.
quotes.
So, just a few housekeeping things. For the physicians in the room, this is an accredited session for 4 hours. So, if you're a family doc, you can count your hours as 3 hours.
Feel free to log them under my name. Yep. Over there.
Is there a number?
And if you're a specialist, this is a Section 3 accredited session for 4 hours. So you can use it under the accredited simulation activity section. So for our debrief, it's going to be a little bit unstructured. What we're going to do is start off with a bit of a summary about what happened in each of the sections. So I'm going to ask Drew to select somebody, Annie or somebody who was in charge down in
Peter.
In Emerge, to give us a fairly complete summary of everything that went on down in Emerge.
Peter, the hate continues.
You want me?
Sure, go for it.
Okay. So, this was a 30-something-year-old man named Nate or Dave or Drew.
Nate Pearson.
Nate Pearson. Yeah, Nate, honestly, name's not very important. So Nate, he was in a high-speed MVC in a motorcycle. The information that we had coming in was that he was hypotensive with an altered GCS. That was kind of it. I apologize for how sweaty I am right now. And so when the patient got here, we did hands-off hangover, got him off the bed, did a quick primary survey. He was found to be hypotensive, tachycardic, and hypoxic. Initially, we were trying to resuscitate him, and the thought was to move to intubation. However, once we kind of found a bit of a period of stability, we opted to do a chest tube. General surgery came down and assisted us, pointed out we should do it on the other side, so we placed the left-sided chest tube first. He improved. Oxygenation improved, heart rate improved, blood pressure improved slightly, but he was still, quite unstable. The plan was to get him to the operating room before intubating him. We spoke with anesthesia, who requested that we intubate him in the emergency department due to staffing constraints. So we intubated him using, an RSI with ketamine and rocuronium, intubated with a glide scope, and then sent off to the operating room.
Great. And then, Scott, you received the patient in the operating room. Can you take our summary from there?
He was reasonably stable at the start. They had already transfused him 4 units of blood. Quickly he became unstable. He had a little bit of anesthesia. With increasing fluids, he continued to become unstable. Took us a little while to figure out that there was a right-sided tension pneumothorax. We got more intravenous access, femoral venous line, art line, and a 16 peripheral. The surgery seemed like it went very fast.
Amazing
They got the bleeding under control. A lab eventually came along and found that his coagulopathy was getting worse. He needed, his fibrinogen was severely low. It took a long time to get the fibrinogen that we never got as far as that mill. We did get platelets, which is quite different from normal, the speed of platelet transfusion in an IMO. And then that was it. He was, you know, a little bit hypothermic, but considering all the fluid resuscitations, we gave him some calcium. He had already had the TXA antibiotics. He the monitors were responding very quickly to, you know, what seemed like might have been adequate treatment, but we gave him some bicarb. And then we were able to send him to the CT scanner, medical imaging.
So, from a general surgery perspective, can you tell us what you did?
Yeah, so I went in, laparotomy, kind of exploratory laparotomy, identified a splenic laceration, liver laceration. We ended up taking out the spleen, packing the abdomen, leaving the abdomen open with just like a simple IOBAN. And yeah, damage control surgery would have been the name of the surgery. Yeah.
So in terms of personnel, when it was discovered that you did need a chest tube, how did you manage to get around that with the surgeon scrubbed, middle of the night?
Someone called an ER doc.
Yeah, our proceduralist was available and
Immediately
placed the chest tube.
Just so fortunate.
And we go all the time with
What would
the
happen at 2 in the morning?
Yeah, that's what I was just gonna ask, is what would
The
happen on the
surgeon
middle
would
of
do
the
it,
night?
I think.
I think the surgeon
They
would
would probably, yeah.
Surgeon would do it?
Would they unscrub and do it and then
They would
re-scrub
just do it
after?
and then
Or
re-scrub.
nursing could
Yeah, not
sterile.
scrub, yeah.
Do it
Yeah.
and then re-scrub.
Re-scrub.
Probably would be my best guess. I don't think the anesthesiologist plays chest tubes.
It's been about 20 years for me though.
Yeah.
For a case like that, would they usually call in a second surgeon anyway, or no?
No.
They
I don't know how that
are-
works.
There is no second surgery.
I have seen it done.
Sorry?
I have seen it done.
One with his left
Very
hand and the other with his right.
Just call
It's
one.
probably
You can
easier in the
call
OR when
ICU.
the patient's unresponsive and paralyzed compared to putting it in as an intern.
Yeah, so he actually didn't need a chest tube, like, he could have had a finger thoracostomy, which is a lot less involved than securing in a chest tube and stuff like that, because he was on a ventilator. So, but again, I don't know who.
Someone
would
still has
be-
to unscrub to do that though.
No, I'm saying, yeah.
But just to carry on with the events, we'll get into the debrief after. So then we came down to radiology. And for a patient like this, can you describe what kind of scans you would typically do?
It was still exploratory, it sounded like, based on how the patient came to us. So we, the classic pan scan, we did CT head, CTC spine, chest abdominal angiogram, and then as well as a portal venous. Wasn't a concern at the time for neurologic deficits, which is interesting based on the findings in the CT. So we would have probably done an angiogram of the head and neck as well, we didn't. Yeah, and usually that protocol, so it was a bit artificial in the sense that protocol would have been happened away from the scanner, and then if something happened, I would get called, but in this case it was there.
So you would have been at home?
No, I potentially, depending on what time, right now I'd probably be here, but just in reading other stuff and then get called in versus being at the scanner. Sometimes
Operating
it
the
happens.
scanner.
Exactly, moving the patient.
Put the patient in.
I was making it up as I went there.
It's the radiologist that does it all.
Exactly.
And then when emergencies happen in the radiology unit, how do you usually manage that? How does it usually run?
So the tech will usually identify that something is going awry, and then call, we have a button that alerts like the whole department that something's happening, call for a radiologist to come into the room. So that's how I would get called in and then start the assessment.
And then if there is a resuscitation that needs to happen,
Yeah.
you do have a crash cart there.
We do, yeah.
And generally speaking, as I understand it, a code would be called, is that right? And then.
Yeah, depending on the situation, yeah, code would call very quickly.
And typically who would arrive at
Emergency usually, but
It's
ICU.
ICU
Okay.
now.
It's an ICU
Yeah,
space.
it's ICU.
It's interesting because ICU is a bit further away.
Yeah. Emerge potentially might show up as well,
Right.
just because we're not sure if this is an emerge patient
Mhm.
or
Yeah.
if this is an ICU patient.
Yes.
But in this situation, it's no longer an emerge patient.
Right.
We don't know that when it's just called overhead,
Yeah.
code blue radiology. So
Emergency
we probably would.
comes
One of us would probably
Yeah,
come
I
down
guess.
too.
Are intensivists here 24/7?
Yeah,
Oh, okay.
yeah, there's somebody in the building.
The other piece too, if it's an outpatient in medical imaging
Mhm.
and a code is called, then that patient inevitably comes to emergency.
But again, still with like outpatient resus or any of those like medical assistants, that's ICU still?
Yes.
Everything outside of
Oh,
emerge
is
is
ICU.
ICU. It's, if it gets called, through the hospital,
Yeah.
ICU is the one that's gonna respond.
Yeah.
Now they're nice and close.
And then typically, emerge doc comes too.
Yeah.
Yeah.
Like
In radiology, we would.
in radiology, we would, because we don't know if it's one of
And
ours.
sometimes CNL. And outcomes.
Yeah.
So Allison, from your perspective as PRT on tonight, do you have any insights into how these things usually run? They're obviously an emerge, facilitating the airway and the intubation.
We're usually following the patient kind of the entire way through until ICU, especially now when we're short, so we're gonna be following them through and then probably setting them up in ICU as well.
And as you could see, it was very helpful to have you in the operating room. I know you're really short, but it is really nice to have extra bodies that are skilled like you guys in the operating room.
And I think I typically do stay up and as long as there's something for me to do. When there's no AAs there, because they're done at 8 or something like that. They're not here.
7:30.
Yeah.
7:30.
If there is someone, there's not always someone.
Yeah.
And this is the first time we've had a unit clerk. Did you have any observations or?
Well, this one was my first one, so I was very grateful to have Matt kind of tag along with me. So it was just like, it was a lot to take in, I think, for like being the first, like my first sim. So, you know, I was just very grateful that like I was invited. So,
From a personnel or department perspective, before we dive into some of the details, does anybody have any comments or thoughts?
On what?
Interdepartmental things or?
Would you always, like I know the patient was not stable, but I'm just used to always going to the CT scanner first before anything else.
Before OR.
Yeah.
I think for this patient who had a positive fast and unstable, that's just an indication to just get the CT scanner for now and go right to the OR for an exploratory laparotomy. So that's why we didn't go to the CT scanner.
Yeah. Typically, you're right, that's the usual flow and that's more ideal because it can identify things that aren't necessarily obvious like the intracerebral bleed, but when the patient is super unstable and he's got a known source, that's another flow pattern is they would come straight to the OR. So we're gonna play a game. And